Hi, I'm Erin Cox, physiotherapist. Today we're going to talk about ligaments at the elbow. A couple of points of anatomy just to start. So we're going to talk about the ligaments on the medial side. So the medial side would be more with the ulna and the humerus. And keep in mind that also if later you're going to test the medial side or you want to mobilize the medial side, that our hand will be on the ulna. And on the lateral side, we have more the radius. So we'll be thinking more about the radius. However, I just want you to take note that the radius sits a little bit anterior to my ulna. So if the radius is a little bit anterior, there's actually room for some ligament attachments here between the ulna and the humerus. So first, if we look at the medial side, we're gonna talk about sort of three different bands. There's going to be an anterior band that's going to go from the humerus down to the ulna. There's going to be a posterior band that's going to go from the the medial epicondyle. And if you've got your elbow in 90 degrees and you go distally towards the ulna, then you're going to hit the posterior band. And then there's going to be an oblique band that connect the two. All three of them look like a little bit of a fan, and they're very important in the medial stability of the elbow. You'll also see we're going to talk about in that anterior band, there's going to be an anterior portion and a posterior portion. So don't get that confused. Like I said, so that would be the humeral-ulnar joint, but you can also have a lateral collateral ligament of the ulnar humeral joint as well. So the lateral collateral ulnar ligament, which sits between the humerus and the ulna. And then we're going to have the radial collateral ligament, which is anterior to it. So the ulnar part is posterior to it, and then the radial part is anterior to it. We'll look at a couple other ligaments as well. I'll just share my screen for the other ones. So ligaments of the elbow. So we have the medial ulnar collateral ligament. Like I said, there are three distinct bands and distinct from the capsule: the lateral ulnar collateral ligament, the radial collateral ligament, and we'll also look at the annular ligament and the quadrate ligament. So these are the three on the medial aspect that I was talking to you about. So this is the anterior band, the posterior one, and then the oblique, which links the distal attachments of the anterior and posterior bands. So the anterior band, the medial epicondyle to the sublime tubercle, just medial to the coronoid process. So it's a little bit, does go rather anteriorly, and it lies close to the axis of flexion extension. It's distinct from the joint capsule. Therefore, it's also, because of these features, it's taut through most of the range of motion. The anterior portion of the anterior ligament is most taut in extension, and then the posterior portion of the anterior band is more taut in flexion. So the functional range, this ligament will be taut from 20 degrees of elbow flexion to 120 degrees of elbow flexion. And it's the primary stabilizer of the medial elbow. So a rupture, of course, would lead to a gross valgus instability in all positions except full extension, where we should have our bony congruency. So unless there had also been an accompanying fracture with that. The posterior band attached above to lower and posterior parts attached to that medial epicondyle, and then it goes down below the margin of the olecranon. It's not as important for the valgus as the anterior one. And then we have the oblique transverse band, which is between the anterior and posterior band insertions. There's a few intermediate fibers descend from the medial epicondyle to the oblique band. It's often not well developed, and it stretches between the olecranon and the coronoid, which are the same bone. It's related to the triceps, flexor carpi ulnaris, and the ulnar nerve. So maybe there's some proprioceptive, or maybe it's there for some muscle attachments. The lateral ulnar collateral ligament, like I said, is that ligament which is situated on the lateral side, so the same side as the radius, but it is situated behind the radius, so between the humerus and the ulna. So it blends with the annular ligament, and it inserts on the tubercle of the supinator crest of the ulna. So this is just so you can see in a cadaveric example, here's the supinator crest and the supinator tuberosity of the ulna, and this is a coronoid here. The lateral ulnar collateral ligament, it's posterior to the radial collateral ligament, like I said. Deficiency of this ligament would lead to posterior lateral elbow instability, and it's an important lateral stabilizer of the elbow. The radial collateral ligament is also lateral, and it's the lower part of the lateral epicondyle, and it blends into the annular ligament as well, and is anterior to the lateral ulnar collateral ligament. The radial collateral ligament and the supinator muscle. So the supinator muscle originates partly from the superficial aspect of this ligament. It's taut throughout normal range of motion due to its origin near the axis of rotation of the elbow. And it may blend with the lateral joint capsule as well, as does the supinator, and the bony architecture, primary factor in lateral instability. And don't forget, the primary feature in bony is because the medial epicondyle extends more distally, so it will block your varus type movement. So this is in a study of O'Driscoll. Basically what it's saying is it's important to the varus stress and posterior lateral rotary instability, the lateral ulnar collateral ligament, but also to not forget that there is also, it's not necessarily the primary constraint, because we also do have the radial collateral ligament. So we have a little accessory ligament here, and this is a nice view to see all of them. You have the annular ligaments, the accessory ligaments, we have the radial and collateral ligament here, and the ulnar collateral ligament. Another point of view here. So the annular ligament is funnel shaped. It's 4/5 of a ring that encircles the radial head. And of course, the other fifth is because of the ulna. Connects the anterior and posterior aspects of the radial notch of the ulna, strong band which encircles the head of the radius and retains it in contact with the radial notch of the ulna. Anterior portion is taut in the end range of supination. We'll look at the biomechanics in a moment. And the posterior portion is taut at the end range of pronation, posterior and pronation. Deep aspect is lined with a thin layer of hyaline and some fibrocartilage. So here's a point of view of the annular ligament, and another viewpoint of the annular ligament as well. We talked about the capsule earlier and the synovium. The quadrate ligament is part of the annular ligament. It's a thin fibrous layer which covers the synovial membrane, which encloses the distal aspect of the superior radial-ulnar joint. So it's distal to the annular ligament. It connects the inferior aspect of the radial notch to the neck of the radius. And its role, it may stabilize the radial head by limiting its spin in pronation supination, or it may reinforce the inferior part of the superior radial-ulnar joint capsule. And here's a viewpoint here. Obviously, it links the radius and the ulna together. Fascia, we have this oblique band up here. It's a small fibrous bundle. It's from the ulnar tuberosity on the ulna. It runs inferolaterally to the radius, inferior to the bicipital tuberosity. Fibers are at a 90-degree angle to the interosseous membrane, and it's separated from it by an aperture which houses the posterior interosseous vessels. There's probably a minimal contribution to stability, although it would seem that it would help prevent against radial inferior, going to inferior, as the interosseous membrane would stop the ulna from going to inferior on the radius, and is it taut in full supination. The interosseous membrane is more taut in mid-pronation and supination, and its main role would be for increasing the surface area for muscular attachments. We also have bursa. We have the olecranon subcutaneous. We have the under each of the epicondyles, or over each of the epicondyles, and also radial ulnar. And this is just a viewpoint to be able to see the different bursa on the anterior aspect and also on the posterior aspect. All right, and there you go. Thank you very much.